The topic what we are going to discuss now. So, if 45 to 50-year-old female, young female lady came to the OPD with chief complaints of vomiting, headache, nausea with diplopia, and without any hydrocephalus or any space occupying lesions on investigations, then what do you suspect in this case? What may be the cause? So, normally it is due to idiopathic reason, which is one of the cause of papilledema. So, let's discuss it, papilledema. So, at last we will also discuss the differences between papilledema, papillitis and pseudopapillitis. So, first of all, what is papilledema? It is a bilateral asymmetrical swelling of the optic disc. So, it should be differentiated from disc edema. Disc edema may be unilateral also, and disc edema may be passive or active edematous swelling, whereas papilledema is passive edematous swelling. So, what may be the etiology? So, etiology may be there is edema, right? Edema is a component of inflammation. So, you remember like inflammation is a cause in etiology. So, inflammation means what inflammations we already discussed. Papillitis may be there, papillophlebitis, neuroretinitis. Remember those. So, as edema is a component of inflammation, here papilledema is there. So, inflammation is also a cause of papilledema. And in inflammation we know Daller, Ruber, Calor, tumor, Dollar, and loss of function. So, we have Ruber component, redness. Redness is due to some vascular pathology. So, vascular pathology is also a cause. Like commonly retinal vessels are there in the eye. So, retinal venous occlusion, central retinal venous occlusion. And another thing is diabetes. We know a chronic complication is like retinopathy. So, diabetic papillopathy also seen. Ocular hypotony means axoplasm mobility will be decreased due to hypotone, and there may be stars of the axoplasm. Okay. So, it may be one of the cause. And orbital causes like so papilledema is there. So, eyes are the reflection of brain. So, if there is any increased intracranial pressure due to some underlying space occupying lesion or tumor, and it may lead to papilledema. So, tumors may be the cause. Graves orbitopathy, due to the deposition of mucopolysaccharides and all, there is a proptosis, which also reflects some increased intracranial pressure. Papilledema also may be there, which is also a cause of papilledema. So, infiltrations like leukemias, lymphocytes. If there is any T cell aggregation there may be swelling in the disc. So, coming to etiopathogenesis, intracranial space occupying lesions like posterior, except in the medulla oblongata. Okay. We should exclude medulla oblongata, and remaining causes should be looked off. So, posterior fossa tumors which obstruct the aqueduct of sylvius, which is present in the midbrain, right? Pituitary tumors, okay, these are least associated with the papilledema. Intracranial space occupying lesions in the cerebellum, midbrain, parieto-occipital region, and another one is fast progressive lesions will develop papilledema faster than the slow progressive lesions. Coming to congenital causes are aqueductal stenosis, cranial synostosis. Cranial synostosis means overriding of the cranial bones. Okay, synostosis, aqueductal stenosis. And another thing is intracranial infections like meningitis, encephalitis, right? Intracranial hemorrhages. You correlated with the etiology. Vascular cause is there. Vascular means vessel. There may be rupture like hemorrhage, you remember. And we had already talked about inflammation. So now meningitis, encephalitis will come there in case of infections. And so vascular, we already said intracranial hemorrhage, cerebral hemorrhage, and subarachnoid hemorrhage. Obstruction of CSF absorptions like via arachnoid villi, and tumors of, already we had discussed, tumors may be the etiology, tumors of the SPC. Okay. Sometimes idiopathic hypertension, bilateral papilledema without intracranial space occupying lesion, enlargement without enlargement of the ventricles, hydrocephalus. Okay, there may be idiopathic intracranial hypertension. So a young lady presented with this, you should suspect papilledema. You should suspect idiopathic intracranial hypertension with these features. As my case also more shows this idiopathic reason, intracranial hypertension. Okay, systemic conditions will be malignant hypertension, pregnancy induced hypertension, okay, blood dyscrasias, okay, and diffuse cerebral edema and CSVT means cavernous sinus venous thrombosis, which may also lead to papilledema. So before what they used to think means there may be some compression of these vessels which may lead to increased ICP and all, leading to this papilledema. Now Hayes theory, which is newest theory, which tells that there is increased ICP due to the raised pressure in the subdural space around the retrolamellar part of the optic disc. So there is disc edema and venous congestion and stasis is there, pooling of the venous blood is there. So disc edema, which is appears like obliteration, findings are obliteration of the, on fundoscopy there may be obliteration of the optic cup and elevation of the optic disc, blurring of the disc margin, spread of edema to the prepupillary nerve fibers, retinal folds which are Panton's lines, and these may be seen in fundoscopic findings. Venous congestion stasis due to the hyperemia of optic disc, peripapillary hemorrhages, cotton wool spots and hard exudates will be seen due to this. So coming to evaluation and recovery. So I want to show those pictures. So after this evaluation and recovery, papilledema increased ICP will be seen within 5 days. Okay, whereas in case of subarachnoid hemorrhage, then papilledema will be visible within 2 to 8 hours only. Okay, recovery from fully developed papilledema is 6 to 8 weeks. So it subsides. Okay, it subsides 6 to 8 weeks after the onset. Unilateral papilledema will see in Foster Kennedy syndrome, which is associated with the olfactory sphenoidal meningiomata or frontal lobe tumors, right? Optic atrophy on the side of the lesion, papilledema on the other side is Foster Kennedy syndrome, whereas already pre-existing optic atrophy and now papilledema on the other side optic atrophy, papilledema is now developed. Already existing optic atrophy is there. This is pseudo Foster Kennedy syndrome. Okay, coming to clinical features, we had already discussed non-specific symptoms are increased due to increased ICP, vomiting, headache, nausea, diplopia will be there. We may think there is diplopia, there may be sixth nerve palsy, which is abducens palsy is there, like that, but it is not, it is like false localizing sign, and focal neurological deficit may be there. Some into clinical features, early we'll see amaurosis fugax, means transient loss of vision. Okay, and ophthalmic features will be now you see here, this is early, right? Early we'll see obliteration of the disc margin, this is disc, right? Disc margins will be, these disc margins may be obscured. Okay, and blurring of the peripupillary margin, then absence of spontaneous venous pulsations at the disc, that is early stage. See, this is early stage, okay. Coming to and there may be hyperemia at the disc, this is hyperemia, mild hyperemia. Hyperemia means increased blood flow at the site, and sphincter hemorrhages at the peripupillary margins. This peripupillary margins, there may be hemorrhages here. Okay, established, second one is established. What you will see means cup of the optic disc will be obliterated, cotton wool spots and cotton wool spots will be seen. Okay, and hemorrhages will also be seen near the disc. This is hemorrhages, some cotton wool spots will be there. There may be hyperemia at the disc side, and tortuous, and veins will be tortuous and engorged. Disc will appear as a mushroom shaped disc, right? And patterns lines will be seen, grayish white folds, separation of the nerve fibers. Okay, hard exudates, okay, macula star will be seen, and visual fields, enlargement of the blind spot. These are the findings of the ophthalmoscope. Visual acuity will be normal, papillary reaction is normal. Okay, transient visual obscuration both the eyes. Next, papers. Chronic long-standing papilledema, visual acuity will be decreased depending upon the duration of the papilledema. Pupillary reactions are normal. Ophthalmic features will be acute hemorrhages and cotton wool spots. This is the third stage. Okay. Ophthalmoscopic features, acute hemorrhages, cotton wool spots will resolve. Peripapillary edema will be resolved. Okay. You see the differences. This is chronic, right? This is this. So now see, this is, there is no hyperemia here, but here it is visible hyperemia, reddish color, and vessels are only some. Here increased vascular supply and disc margin. See how it is there and how it is there. Okay. So peripapillary edema will be resolved. Optic disc, dome of the champagne cork appearance will be seen. Central cup remains obliterated. Small drusen-like crystal deposits. Corpora amylacia. Like it may be this. This is the corpora amylacia, I think. Visual fields, blind spot will be enlarged. Visual fields will be constricting. Atrophic papilledema, 6 to 9 months of chronic papilledema. Severe impaired visual acuity, light reflex will be impaired. Ophthalmic features will be post-neuritic optic atrophy, grayish white discoloration and pallor of the disc, atrophy of the neurons, and associated gliosis will be there. Prominence of disc will be reduced in spite of the raised ICP. Okay. Retinal in retina we'll see narrowed veins. Okay, congestion. So these are the features of ophthalmoscopic features of last stage, which is atrophic. See here it is atrophic. See there is difference. Do you observe all the differences? See this whitish sheathing will be there around the vessels. There is whitish sheathing around the vessels. And visual fields, concentric contraction of the peripheral fields appear as atrophy. So differential diagnosis will be pseudopapilledema and papillitis. Due to this elevation of due to the edema, elevation of the disc will be there. Optic disc drusen, hypermetropia, and persistent hyaloid tissue. Treatment, emergency hospitalization is required. CT scan, MRI with gadolinium enhancement should be done. Okay, cerebral decompression should be done. This is all about papilledema. So on closing this, we'll see the differences between papilledema, papillitis and pseudopapillitis. So first one is papilledema bilateral, whereas papillitis is unilateral. Pseudopapillitis may be unilateral or bilateral. Okay, and visual acuity, transient attacks of blurred vision. Later vision decreases due to the optic atrophy in case of papilledema, whereas marked loss of vision, which is of sudden onset in papillitis. Defective vision depending upon the degree of refractive error in pseudopapillitis. And pain and tenderness is absent on papilledema, whereas on movements, on ocular movements, it is present in papillitis, absent in pseudopapillitis. Pupil normal reaction in case of papilledema and pseudopapillitis, whereas RAPD in case of in unilateral cases, in case of papillitis. Color vision is normal in case of papilledema and pseudopapilledema, whereas papillitis, whereas often impaired red desaturation papillitis. Fundus examination, media is clear in case of papilledema, whereas posterior vitreous haze is common in papillitis, clear in case of pseudopapillitis. Disc color, red and juicy appearance, reddish in papillitis, pseudopapillitis, and papilledema, red and juicy appearance, and blurred in case of papillitis and papillitis and papilledema. In pseudopapillitis, it is not well defined. So, disc swelling is 2 to 6 diopters in case of papilledema. Papillitis not more than 3 diopters depending upon the degree of the hypermetropia. Pseudopapillitis may occur. So, peripapillary edema is present in papilledema and papillitis case, whereas absent in pseudopapillitis. Venous engorgement more marked in papilledema, less marked in papillitis, not present in pseudopapillitis. Okay, retinal hemorrhages marked in case of papilledema, not present in papillitis, not present in pseudopapillitis. Retinal exudates are more marked in papilledema, whereas not present in papillitis and not present in pseudopapillitis. Macular star may be present in papilledema. Macular fan may be present in papillitis, absent in pseudopapillitis. Fields enlarged blind spot in papilledema. Central scotoma more for colors in papillitis. No defect in pseudopapillitis. In angiography, vertical oval pool of dye due to leakage in papilledema. Minimal leakage of dye in papillitis. No leakage of dye in pseudopapillitis.